Hello, my name is C.B. Mamaril, and on behalf of the Systems for Action National Coordinating Center, it is my pleasure to welcome everyone to today's Research and Progress webinar on understanding rural-urban differences in the implementation of population health activities. Before we get started, we would like to acknowledge the funding and support of the Robert Wood Johnson Foundation, and I'd like to remind everyone that if you have a question about the presentation, that you can type in your questions at the lower left-hand corner of your screen in the chat box. So without any further ado, it is my pleasure to introduce you today our presenter, Dr. Lava Timsina, who is responsible for developing, maintaining, and analyzing clinical outcomes data at the Center for Outcomes Research in Surgery. He also advises on research study and database design, analysis, and selection of outcome measures at IUPUI. Dr. Timsina recently completed his PhD in epidemiology and biostatistics at the University of Kentucky. Lava obtained his MPH degree with a concentration in epidemiology from the University of Nebraska Medical Center and his undergraduate degree in public health from Tribhuvan University in Nepal. So without any further ado, I'd like to turn it over to you, Lava, for your presentation.
Thank you, CB. Good afternoon, everyone. Thank you, CB, for your wonderful introduction. Today, I am presenting a work-in-progress study that I conducted while being at the University of Kentucky using the data from a unique survey, the National Longitudinal Survey of Local Public Health Systems, which is commonly referred to as NLSPHS. The topic for this presentation, as CB already mentioned, is understanding rural-urban differences in the implementation of population health activities. Before going into my presentation, I would also like to acknowledge my co-authors, Dr. Mays, Dr. Hug, Dr. Mamaril, Dr. Ingram in this study. Besides, I would like to thank Dr. Nathan Hale and Public Health Director Drew Beckett for agreeing to participate in this webinar and provide the commentaries from the research and practice perspectives. Thank you, System for National Coordinating Center, which was key in helping me providing a platform to conduct public health systems and services research while pursuing my PhD at the University of Kentucky. The main objective of this study is to examine the rural-urban differences in the scope of and multisectoral contributions to population health activities. Let me first set the background. So there's an ample evidence that indicates rural-urban disparities in the U.S. Rural communities have poor health status, are less insured, and have less access to preventive care measures. Rural communities are more likely to experience higher mortality rates from preventable causes. Compared to urban communities, there's a new study done by CDC that demonstrates that Americans living in rural areas are more likely to die from preventable conditions such as heart disease, cancer, unintentional injuries, chronic low respiratory disease, and strokes. Compared to urban areas, the prevalence of diabetes is significantly higher among residents living in the rural areas across all races. The unintentional injury mortality rate for most rural counties was almost 2 times higher than that observed in large metropolitan counties. Despite an improvement in overall life expectancy in the U.S., there is still a widening gap in rural-urban differences in life expectancies over time. These differences in health status between the rural and urban communities may not be attributable only to the differences in access to medical care, but also to multiple components such as characteristics of health delivery systems, characteristics of population at risk, and some external environments. In addition, there may be rural-urban differences in the availability of population health activities that extend beyond medical care and target social, economic, and environmental determinants of health, such as poverty, education, spending on public safety, social welfare services, housing, and unemployment, and healthcare access between rural and urban communities. Traditionally, the rural population health service delivery system emphasizes access to care through direct service provision as a fundamental principle of health services delivery and a primary approach to meeting the population health needs of the rural communities. However, most healthcare problems reported in rural communities that are preventable are related to risky health behaviors, lack of access to health education, lower utilization of healthcare services, and increasingly aging population. Thus, the rural population may be well served by a health system that provides access to a more comprehensive package of core population health services. The rural public health agencies generally are constrained by resources and fundings. As such, they may not have the capacity to offer a complete package of these preventive services on their own. One strategy to overcome resource limitations is to distribute the burden of efforts by partnering with other collaborators within the public health systems in the community. So this study examines the rural-urban differences in the scope of and multisectoral contributions to population health activities using a system approach. Let me first provide some definitions because I will be frequently using these terms throughout my presentation. Population health is defined as the health outcomes of a group of individuals, including the distribution of such outcomes within the group. These groups are often geographic populations, such as nations or communities, but can also be other groups such as employees, ethnic groups, disabled persons, prisoners, or any other defined groups. The health outcomes of such groups are of relevance to policymakers in both the public and the private sectors. Public health systems are commonly defined as all public, private, and voluntary entities that contribute to the delivery of essential population health services within a jurisdiction. This concept ensures that all entities' contributions to the health and well-being of the community or state are recognized in assessing the provision of population health services. This study uses a list of 20 population health activities which are identified from a series of survey of local health department directors and were considered as the indicators of local public health performances. Each of the 20 population health activities can be grouped into one of the three core domains as defined by IOM, such as assessment, policy development, and assurance. Now this brings me to introduce you all about Analyst, which is the only longitudinal survey of local health jurisdictions that tracks the performance of local public health systems by examining the availability of these 20 recommended population health activities, perceived effectiveness of these activities, local health departments' contribution to each activities, and the multisectoral participation of other agencies that contribute in each of these activities. As such, Analyst is the only source of longitudinal data that can be analyzed at system level and can be used to define the typology of the system. In 1993, since 1993, researchers are assessing availability and adequacy of community-level essential population health services and have generated ample evidence of gaps and variations in terms of performances. Given a wide variation in organizational structure of public health delivery systems, Mays et al. Identified 7 distinct organizational configurations that can be grouped into 3 tiers of systems: comprehensive, conventional, and limited systems. Let me define each of these systems. Comprehensive system is defined as the system that ensures a broad scope of population health activities in a community in collaboration and contributions through dense networks of other agencies within a public health system. A conventional system is defined as a system that offers moderate scope of population health activities through lower density of networks of contributing agencies, whereas a limited system has a narrow scope of the population health activities implemented through lower density networks of contributing agencies. Each of these major categories can be subdivided into other subcategories based on the roles of the local public health agency in the system's network. That is, whether they play a more central role or less central role in ensuring population health activities. In this study, I am more interested in looking at rural-urban differences in comprehensive systems versus others. This slide shows us the demand and supply framework to healthcare And I have used this framework to describe the rural-urban differences in population health delivery systems and services. At population level, demand for healthcare is affected by socioeconomic characteristics of population such as sociocultural norms, income and poverty status, educational attainment, unemployment rates, and access barriers. The supply of healthcare includes broad spectrum of economics on such topics as production theory, input markets, and industrial organizations. The interaction between demand and supply of healthcare produces a market equilibrium that provides a basis to examine public health systems, such as how well is the system performing? Is it accessible? Is quality at desired level? So this framework can be used to examine the geographical differences in the scope and multisectoral contributions of population health services. Let me talk in detail about the framework. A simple supply and demand framework can be used to evaluate how selected supply and demand factors contribute or give rise to differences in population health activities between rural and urban communities. Demand for healthcare is a function of population characteristics such as socioeconomic cultural norms, income, poverty status, education, unemployment rates, and access barriers. Compared to urban communities, rural ones have higher aging populations, greater prevalence of risk factors associated with chronic health conditions, a socioeconomically less stable population with higher poverty, lower education, and higher unemployment rates. Mortality is also higher in rural communities. All of these factors dictate disparities in demand for healthcare between rural and urban communities. Towards the supply side, consider first community capacity to supply population health activities, where rural public health systems significantly lag in terms of infrastructures, workforce capacity compared to urban public health systems. Rural public health systems are also characterized by lower funding levels, limited access to grant fundings, lack of specialized medical care providers, problems in recruiting and retaining staff, limited access to transportation, wide geographic coverage area with small workforce, smaller health centers with limited budgets, and fragmentation among limitedly available resources within rural communities. Another factor affecting the disparity in supply of rural versus urban population health activities are the substantial differences in the physicians, services, and health insurance markets in rural communities. For example, only 11% of the physicians practice in rural America, despite the fact that 1/5 of the population lives in this area. If you look at the physicians population ratio to every 100,000 population, the national ratio was 191, but there was a large disproportionate variation between urban and rural communities, 210 versus 52 per 100,000 populations. The interaction between demand and supply of healthcare provides a market equilibrium that provides a basis to examine public health systems. Given the differences between rural and urban areas as it relates to the overall supply and demand conditions for population health, we would therefore expect to find differences in the availability, scope, and multisectoral contributions in population health activities. So we used a cross-section of Analyst Pictures data from 2014 waves, which not only has the data from the 1998 cohort of large-sized jurisdictions serving at least 100,000 population, but also includes an expanded cohort of small-sized jurisdictions that serves less than 100,000 population. And this allows us to make a comparison between rural and urban communities. We linked Analyst Pictures with county-level demographic, socioeconomic characteristics, and healthcare resources from the Area Health Resource File and the 2013 Nature Profile Survey. We used the Rural-Urban Continuum code to define rural and urban communities. Those jurisdictions serving in the metropolitan counties were regarded as urban, and those in the non-metropolitan counties were rural jurisdictions. In total, there were 176 rural jurisdictions and 348 urban ones who responded to the survey. Because there were counties driven from same state, we also controlled for the correlation between LHDs within the same state with an assumption that they bear similar characteristics. This is the detail of the Rural-Urban Continuum code that was used to classify between rural and urban counties. So if you see over here, we classified non-metropolitan areas with rural-urban continuum code greater than 3 as rural counties, and all communities with rural-urban continuum code less than or equal to 3 as urban counties. So the dependent variables that we used in the study were the composite measures of the availability of all 20 population health activities, comprehensive system configuration of each public health delivery system. And rural-urban communities were our main independent variable of interest, and we control for a range of variables that are related to demographic, socioeconomic, and healthcare resources in rural and urban communities. We used stratified generalized estimating equation in the analysis. Stratification was done by rural versus urban. For analyzing the total availability of population health activities, we used linear link function, and for analyzing the comprehensive system configuration, we used logit link function in generalized estimating equation. Both of these models were adjusted for the effect of clustering due to LHDs being in the same state. By LHDs, it's the local health department. We used unstructured correlation structure for the error term. Multicollinearity was tested, and estimates were weighted using the inverse of selection probability as the weights. So when compared to rural jurisdiction, the descriptive statistics over here show that the urban jurisdictions on average had significantly more health resources, such as per capita hospital beds, physicians, and federally qualified health centers. Community in urban jurisdictions also have a higher proportion of non-white population, higher income per capita, and lower rates of total uninsured when compared to rural jurisdictions. There were also many city-county type of jurisdictions in the rural communities. This slide is a bit busy, but it presents the frequency of communities with each of the 20 population health activities. The final 4 rows presents the mean scores for the performance and assessment, policy development, assurance, and the mean score for overall activities. Because this is too busy, I have truncated this into only those activities that were significantly different between rural and urban jurisdictions in the next slide. So systems serving urban communities were significantly more likely to report informing elected officials about population health issues. We're more likely to analyze health determinants, to develop a community-wide health improvement plan, and to monitor and improve implementation of health programs and policies. When compared to urban communities, public health systems serving rural communities were more likely to implement mandated population health activities and health initiatives in priority areas. At the more aggregate level, systems serving urban populations had a slightly higher proportion of overall assessment, policy development, and assurance activities. Public health systems serving urban population performed 66% of the 20 population health activities, while those serving rural communities performed a lower percentage, that is 62%. The asterisk in that figures in those composite scores shows they were significant at 0.05 level of significance. This graph shows the distribution of 3 different types of public health systems, comprehensive, conventional, and limited, observed in rural and urban communities. There was no significant differences in the types of public health systems between rural and urban areas. Most urban and rural communities were served by conventional public health systems, those that offer a moderate scope of population health activities with fewer contributing organizations and sectors. However, conventional public health systems were more common in rural communities than urban ones. Comprehensive public health systems were observed more frequently in urban than in rural communities. Now, this slide and the following one present results from the stratified multivariable analysis. Only the significant predictors are presented in the slides. Here, the centralized rural communities were performing about 0.19 percentage points less population health activities than non-centralized rural communities. However, this difference was not significant in urban settings. For each unit increase in the population density in urban communities, number of population health activities increases by 0.05 percentage point. However, population density was not significantly related to availability of population health activities in rural communities. the proportion of population health activities performed in city township jurisdictions is about 0.62 percentage points lower than in county or city-county jurisdictions. However, this gap was less for urban settings, where only 0.1 percentage points lower proportion of population health activities were performed in city township jurisdictions than county or city-county jurisdictions. We can also see over here that the interaction effect of total uninsurance rates and the number of FQHCs, federally qualified health centers, per 10,000 population below poverty level, and that of percentage of non-white population and income per capita were observed to be significantly more in urban communities than in rural ones. This slide presents stratified results from the adjusted odds ratio for being in the comprehensive health system. We see that in the rural settings compared to non-centralized jurisdictions, the centralized jurisdictions are less likely to be in comprehensive public health system. However, this difference was not significant in metro settings. Depending upon the percentage of uninsured population in a community, there exists different effect of federally qualified health centers per 10,000 population below poverty level on whether a public health system is comprehensive or not. Now, it is a little bit difficult to interpret an interaction, but I have tried to interpret this one based on the mean value for insurance rate. So what happens for each unit increase in FQHC, when we hold the uninsurance rate at mean value within a communities, we see that it will produce an increase in odds of being in comprehensive public health system by 18.6 times, which is huge. Urban communities where percentage of non-white is more are less likely to be the comprehensive system. However, there might be an interaction effect with income that we might consider to look into for more detailed conclusion. In urban setting, increase in number of physicians and hospital beds were less likely to favor comprehensive public health system. And this might be due to the fact that increase in these medical resources will deviate the funding and programs more towards clinical problems that usually bring a patient to a physician's office rather than ensuring provision of the population health services in the community. So, on an average, urban communities perform 7% higher number of population health activities compared to rural ones. Population density in urban communities predicted greater availability of population health activities. This might be due to the fact that there are more working adults in the urban communities when the rural communities is aging and includes retiring population as well. This might lead to generate increasing local tax bases in urban communities than the rural ones, and that might have increased the funding and availability of population health activities more in urban communities. The centralized rural communities have fewer number of population health activities and also have non-comprehensive population health systems at local level. However, in urban areas, this relationship was not observed. This might be an indication that a decentralized government authority in rural communities may be more informed of and responsive to local communities. In contrast, in urban communities, the benefits of decentralizations could be outweighed by the advantage of the size and economies of scale achievable through centralizations. The federally qualified health centers per 10,000 population below poverty were associated with non-comprehensive population health system. The primary health care services in FQHC program generally include treatment of acute or chronic medical problems rather than ensuring provision of the population health services in the community. All of our findings may reflect that rural public health systems face limited financial resources, are focused more on clinical services in the presence of fewer medical care providers, or have population with poor health status and greater health disparities. By contrast, compared to urban communities, rural communities that are constrained with limited resources and lower population health system capital may have less capacity and flexibility to deliver the recommended population health activities. The presence of dense networks of contributing organizations and sectors serving urban populations coupled with a higher resource and income base may facilitate the provision of these recommended health activities. So, limitations. By design, this is a cross-sectional study. We took only 2014 waves and may not reflect the causal relationship. Because the survey was self-administered, it may also not have reflected all relevant activities and contributing organizations in the community. Also, Analyst does not collect information on concentration, value, and quality of the population delivery services. Implications. Comprehensive system capital in metropolitan communities, urban communities using longitudinal studies has been linked with lower mortality rates. Hence, building a multi-sectoral system capital ensuring greater viability of population health status. Rural communities with resource-limited settings can achieve this through sharing of resources, community participation, and collaborations. In addition, strengthening capacity of rural public health system in resource allocation planning will help them to better manage their valuable resources and provide a comprehensive set of population health activities in the communities through effective participation of the entities of a public health system. Future directions. We are planning to expand our cross-sectional study design and have at least another wave of analyst picture survey to compare and contrast the trend of population health activities and system configurations between rural and urban communities. We are also planning to link our data set to examine the effect of public health systems configurations on mortality rates, more objectively measured outcome between rural and urban communities. And that brings to the end of my presentation. Thank you, and I would love to hear your comments and feedbacks on this. You can also email me your thoughts to my email address. Thank you all.
Thank you, Lava. Excellent presentation. Before I introduce our commentators for today, I'd like to remind everyone again that if you have questions about the presentation, that you can type them in the chat box in the lower left-hand corner of your screen. And actually, we have a couple questions already that we'll get to later. It's my pleasure to introduce to you our commentators for today, starting with Dr. Nathan Hale, who is an assistant professor in the Department of Health Services Management and Policy at the East Tennessee State University College of Public Health. Nathan's research interests include public health services and systems, maternal and child health, and rural health. And his work has examined the role of local health departmental clinical services on services received and outcomes among rural and vulnerable populations. Nathan has also served as the primary investigator on multiple statewide projects aimed at improving the health and well-being of women and children, and previously Nathan also worked in public health practice at the local, regional, and state level. Nathan's comments will be followed by Andrew Beckett, who is the Public Health Director for the Bourbon County Health Department. Drew was most recently named the Trailblazer Award winner by the Kentucky Health Departments Association as the most outstanding director with less than 5 years of experience. Drew is also currently the Kentucky Public Health Association president and also maintains an active role on many boards serving Bourbon and Scott counties. And he received his MPH degree from the University of Kentucky. So with that, I'd like to first turn it over to you, Nathan, for your comments.
All right. Thank you, CV. First off, thanks to Lava for the presentation. It was certainly informative, and thank you to the Coordinating Center for the invitation to offer some additional comments on the research. So thinking about the importance of this research and how it fits within the context of systems and services research around building a culture of health, I just have a few big picture comments and then a few comments about some of the specific findings and the implications that I think are somewhat important. So let me start first with the observation that you would expect from someone with a background in rural health research. Personally, any research that provides a better understanding of rural public health systems, and particularly the role of rural local health departments within those bigger systems, I think is pretty important and much needed for the field itself. So not many public health system studies that we have out there are exclusively focused on rural public health, and the ones that we do have tend to be pretty limited in scope or methodology. So this research, in my mind at least, is focused on services and systems within the rural context, but it also kind of widens scope of research by using a more robust data set and looking at more than just a single stage and so on. So I think both of those issues really move the field forward from a research perspective. My second comment would be that, a lot of this research in many ways provides validation for what we suspect to be true about rural public health systems intuitively, but we have a very difficult time quantifying that empirically. So as Lava pointed out, we know that rural communities and local health departments face a lot of challenges that can be quite different than urban health departments and urban public health systems, both in terms of community makeup and in terms of the capacity of the overall system to address the prevailing health issues facing these communities. But really at the same time, we just don't have a lot of studies that we can point to that provide some type of empirical evidence about how these realities manifest in terms of actual public health service delivery, or how some constellation of factors ultimately kind of work together to undermine the ability of the local public health system to devote resources that are needed to improving health in these communities. So, this research provides some insight into what's actually occurring in practice, specifically as it relates to population health activities, which is something I think is particularly important for rural public health moving forward. So that would kind of bring me to my third point, which is documenting these challenges and how they manifest in rural-urban differences is really critical for informing the discussions on the tools and the strategies, and the policies that might be needed to close the gap between rural and urban health department performance, to the extent that that's appropriate. In a lot of ways there are always going to be rural-urban gaps just by function of, volume and where they sit geographically. But the degree to which that gap can be closed, I think, is something that's important to take a look at. So, this research highlights one of those key areas, which is the ability to engage in population health activities. So I think that's pretty important, particularly as Lava pointed out earlier that, the leading cause of death in rural communities tend to be fairly amenable to public health intervention. So it's in my mind, it's important that rural local health departments are very well situated to address those issues. And, this research gives us an additional piece of information to work with for those of us who are engaged in rural health advocacy and feel strongly about advocating on behalf of the 50 million Americans who live in a rural community. So those are just kind of some big picture observations that I have about the research and how it fits into, building a culture of health and systems and services research. So a little bit more specific to the research findings and the implications, there are a few things that I would point out. I have to be honest and say that, the rural-urban differences that I see in the findings that Lava pointed out are a little bit encouraging. The gaps between rural and urban performance around this issue are not quite as significant as I would have expected intuitively based off of my own history and personal experiences. Given that you have a list of 20 activities and really only a handful were significant, and the ones that were significant fell out pretty much like you would expect based off of the context in which rural and urban health departments operate. I actually found that to be fairly encouraging. Now, this could very well be a function of how, questions are interpreted and, how the instrumentation works. It doesn't really seem to account for the breadth of those services, and they can still look very different between rural and urban. But at least in my mind, the differences didn't strike me as being vast, which I think is somewhat encouraging. Some of the implications, trying to take the research that's here and move it into actionable ways that, we can start to address these issues. A couple of strategies that caught my attention that Lava mentioned I would just like to comment on. One was specific to, looking at cross-collaborative partnerships within these public health systems in rural communities to distribute the burden, right? So not just the local health department, but finding other folks in the community that can help with population health activities. The second one is somewhat related, and that's to cross-jurisdictional resource sharing in rural communities. I think both of these are certainly solid, and they're very appropriate strategies, and these may work very well in some of your larger, more suburban rural communities, if that makes sense, places where you have a critical mass of support that you can actually work with. But I think that we also have to keep in mind that a lot of rural communities, whether it's by geographic isolation or physical barriers, some of those issues are just going to be a little bit more difficult. In a lot of rural communities, you don't really have a robust partner network to help distribute that burden if you're a local health department. So I think that that's something that we just kind of need to keep in mind as we think about how to come up with solutions and strategies for local health in rural communities. Now, the other one that caught my attention was specific to creating community coalitions and engaging the community in broad-based planning. And regardless of whether you're a bigger rural community or a smaller rural community, I think this one is particularly important. I don't know that this is specific to rural, but if you know anything about rural and just, hands above the table, I grew up in rural communities and spent most of my life living and working in rural communities. And if you know anything about rural culture, you know that ultimately the solutions to addressing these issues are going to have to come from within. And the degree to which those of us who work in public health can engage in those conversations in a way that is respectful, that works to elicit action on behalf of those who are vested in the community, I think is ultimately going to, be the route for us to go. So one final comment real quickly, and there was a lot of talk about centralized health systems and how those differ in rural versus urban. And I have to say, in my mind, centralized health systems tend to be in predominantly rural states that historically provide more clinical services in general, but they're also dealing with historically disadvantaged populations. So there's a tremendous amount of need, but that's also met with a limited amount of capacity in a lot of areas in those particular systems. So I think that's an important finding that really kind of needs to be pulled out and focused on a little bit, specifically as it relates to building a culture of health and addressing those types of health issues. So for the sake of brevity, I will stop there and hand it back over to CB and Drew. Thank you.
Thank you, Nathan. And I'll hand it over to you, Drew, for your comments.
All right, thanks, CB, and thanks again to Lava for the presentation. And also, Nathan, thank you very much for your comments. I guess as I was sitting here listening along with everybody else, the big word that came to my mind through this is validation, because I feel like we live this presentation every day, and I think I was selected to comment on this because I worked at the Lexington-Fayette County Health Department for 4.5 years before coming to the Bourbon County Health Department, both in Kentucky, and actually the counties border each other, but they couldn't be much different. They couldn't be any more different, I guess, than they are. So Lexington usually hovers or is a little more than 300,000 people, I think, in that city and county, and whereas Bourbon County, where I am now, has a total population of 20,000. So it's about night and day. When I was in Lexington, I was over community education and had a staff of 15 just within that field, and now here at the health department in Bourbon County, I have a staff of 13 for the entire health department. So we're doing everything, basically everything that Fayette County or most every health department in Kentucky does with that amount of staff. So I guess it's all relative, but when you talk about resources and the things you have available, that's kind of a real-world example for all of you out there listening. Some of the things, again, Nathan touched on so much of the stuff that I was going to say, so I am not going to say that again. But as far as practice goes, I'd say in the more rural areas, you wouldn't think it, but it's almost more difficult to reach people than in urban areas. As an example here, we just have a weekly newspaper, and that's really the best way to reach people. So that comes out every Wednesday. So if you have an event that's happening, on a Tuesday or something, you don't get the word out in time, then you're in a bad way. So it's just tougher to reach people easily, I guess is what I would say. Kind of access to services, both provider services, medical services, but also just kind of exercise facilities, healthy foods, a lot of those kinds of things. Access is just more difficult, I would say, here than in more urban counties. Again, we have fewer staff, fewer resources, so therefore we kind of lack some of that capacity that larger areas have, is what I would say. And the way our funding comes down to us doesn't really help those things. Here in Kentucky, we've really worked on that, trying to change the funding to more of a funding people or funding health departments to get people to do more population health services instead of so many clinical services. Again, those of us here that are working on that project, we see the value in population health and public health and getting more bang for the buck versus the one-on-one clinical services that take place in a public health setting. Again, those are important and need to happen some, but we feel like there's a much greater impact here and even urban areas when you can do those population health, broader kind of things. I will say some benefits to being in a smaller town that we found. It's much easier to work with local officials, so whether that's your mayors in the city, or here in Kentucky we have county judge executives as our county administrators, school superintendents. I probably could get off the webinar now and call all of them and get a meeting by the end of today, whereas trying to do that in Lexington or Louisville or a bigger city even throughout the country, I think that would be very difficult, if not impossible to do. So that's good. And we've found it here that it's not as difficult to create coalitions. You do have to work harder at first to develop those relationships or find those key stakeholders in the community that are really your health supporters and backers. But once you get them, you can kind of form those coalitions and really try your best to get things done. Without coalitions or without those community groups, there's no way just the health department can do that. The health department can certainly be a leader in getting those coalitions started, and I think we did that here through our community assessment and then our community health improvement plan process. So I think Dr. Hale is exactly right, saying it has to come from within the community here in a smaller community, and that is 1,000,000% right. But your local health department can be that driving force to kind of get it started, or at least help identify some problems or help clarify some community issues. So, whether it's the health department doing it, or we've also partnered quite a bit with our local chamber of commerce or our local school systems, as long as those key stakeholders come from within the community, you can have some success when it comes to working on health issues in a community. But I think that's all I have as far as practice-based. Lava, again, I think you've done a great job, and like I said, it was really, validation was the word that came to mind as I'm sitting there reading what you said. I think we're all getting the job done in more rural areas, trying our best, but it is difficult, and you are stretched thin. And I know even here as the director, I can hire and fire people, but I'm also the head snow shoveler, the head maintenance man when it comes to working on clogged toilets or changing light bulbs, all those things. So we're all doing about 20 different jobs at the same time. So I'll turn it back to you, CB and Lava. That's all I have.
Thank you, Drew. Thank you, Nathan. Those were wonderful commentaries, very insightful. And so before we turn it over and get questions and comments from the audience, Lava, I'd like to give you the opportunity to respond to Nathan and Drew's comments. Give you some time to respond to them.
Yep. So Nathan and Drew, those were all excellent comments. And then I would actually I was actually more encouraged to send these paper for publication after hearing your comments. And I was thrilled to hear that this was a kind of validation study that you guys are experiencing or finding around rural and urban communities. There's not much comment to make on their comments, but I would like to yes, definitely we have to encourage the communities within the community that we're looking into to have them more participation in community level planning, implementation and evaluation of population health activities, and that would definitely give us rise to some better strategies to address these disparities within the communities, because community people know the problem. Community people know how that can be solved. So it's just like tapping those opportunities from within the community that we can use in different policy implications that would address the disparities. And the other comment is, it's actually not a comment, but an appreciation that the hard work that the rural communities health workers are doing, the rural community workers in the public health systems are doing, despite Drew mentioned, he mentioned that he is in one time of a day he is the director, but in other time he might be shoveling snow. So that's definitely, we appreciate your hard work. And then we would be using some additional data that we collected in 2016 waves of analysis just to strengthen our validation study and have a more robust kind of conclusions on regarding the disparities in rural-urban population health activities and performances. That's all I have. Thank you, CB.
All right, Lava. So we got a lot of several comments and questions, and I can't promise that we'll be able to get to all of them, but if we don't, we'll make sure to forward them to Lava. And there's actually some questions that I also want to throw out to our commentators too as well. So I'll save that to the very end. So let me sort it in such a way, Lava, that we'll first begin with some methods-related questions and comments. So we have a comment from Sergey. How do you define rural community as having less than 100,000 population? Community would say 90,000 people. Does not look rural to me. So let me bring up the slide, Lava, so you can explain how these communities were defined in terms of what was rural and urban, and we'll take it from there.
Yeah. So basically, we didn't define the the survey started in 1998 using the population as the cutoff. So we collected those jurisdictions which were serving at least 100,000 populations. But in 2014, we expanded our cohort to include those serving less than 100,000 population. We did a sample. We collected a stratified random sample based on population categories and the region, U.S. region, geographic region, and collected about 500 of the local health departments from the 2013 Nature Profile Survey. So that would give us an opportunity to identify those LHDs based on the county FIPS code, link them with the area health resource file, which has the information about rural-urban continuum codes, and we use these criteria to basically distinguish between rural and community. So it's not 90,000, but basically if your county is in a metro area of fewer than 250,000 population, but is in metro areas, and that is a rural county. County in metro areas of less than 1 million population are rural. So so these are the basically this is the RUCC code that we use to distinguish between rural and continuum. It's not defined mainly only on the population.
Thanks for clarifying that, Lava. And so a related question from Laurel is, what were the rural states you studied? So I guess this would be the rural areas in all the states that were covered by the NLS-BHS. Do you have an idea of how many states would that be, Lava, that had these rural areas that were part of the survey at the top of your head?
At the top of my head, I don't have, but actually we did a sampling of all states that participated in the Nature Profile Survey. So I guess because the Nature Profile Survey is a representation of the population of local health departments in the state, so I would assume that we had pretty much have a representative sample of those rural communities in the state.
Excellent. So same comment from Laurel, who said that in their rural community in Vermont, they actually have found it pretty easy to collaborate with a wide variety of healthcare, public health, human services, state agencies, and community-based not-for-profit. So they're inviting, I guess, people to study their rural healthcare system. So thank you, Laurel, for that comment. Royal also has a question, since you mentioned in your future steps, future study using the 2016 expanded NLSPHS. They're interested to find out information when that be completed. So do you have any idea, Lava, when you'd start doing analysis using a 2016 wave?
I would love to start it as soon as possible, and probably we might have to start it as soon as possible because we are closing the survey in probably by the end of this month.
Actually, the survey is already closed, Lava, so the data set should be ready for now.
The data set should be ready for internal use right now because we have to go through a lot of cleaning process, and once that is done, then it should be the publicly available data should be available, and it has to come through a request through System for Action National Coordinating Center, right, CB?
Right.
And they might have to go through some data user agreement process to get that data.
Yes. So I'd like to end it here. There's still a couple questions. I think this is a good way to end the webinar, and I'd like to get our two commentators to also share their comments and insights. Rael has a comment. Given the potential threat of decreasing local, state, and federal public health budgets in the near term, what steps can lawmakers or policymakers take to reduce the discrepancy between rural and urban population health system implementation? So I'd like to invite Nate and Nathan and Drew to sort of take a stab at this question.
Drew, you want to take it first?
Sure. Gosh, even at a local, state, federal level, I think we're always trying to meet with legislators to explain to them the differences in things that we see, rural versus urban, and that comes into play through the Kentucky Public Health Association that I do. Trying to think for the entire state that has both types of areas. It's just different, and we have to prove. I feel like we have to prove all the time our value, and the more we have numbers and studies like this to show the things we're able to accomplish and what we're able to get done for the public's health, then I hope that will help our funding sources and our streams. I'm not sure. Hopefully I answered a part of that question, but if not, I can be more specific.
Yeah, I guess I'll just add in that, I think the premise of the question is right on, and the way that the federal funding allocation is headed, that certainly could create some potential difficulties across public health, not just specific to rural health departments. And I don't necessarily have an answer other than to say resiliency is key. And if public health is not a lot of things, but one thing public health is resilient because we've been used to working with less for a long, long time. So I think it's going to be a difficult circumstance and situation, but, we're just going to have to get through it just like we always do.
Thank you, Nathan. Thank you, Drew, for your insights into that comment and question. Lava, any last comments, last words, maybe policy implications that you'd like to add?
No, just like Drew mentioned that because of easy accessible to the policymakers, the community level representatives, the elected officials in the community, we can grasp that opportunity and then get them informed about the community health status, and then help them and encourage them to come up with policies that would address the gaps in rural-urban disparities and improve the population health activities in the rural communities.
Excellent, excellent. So with that, Lava, thank you so much for your time in presenting your research, and we'd also like to thank also our commentators, Nathan Hale and Drew Beckett also for their time and their comments and their insightful commentaries. We really appreciate it. We'd like to remind everyone that today's presentation is available, has been recorded, and is available for download from our archive. So we invite you to visit the Systems for Action website. And also past presentations that you might be interested in are also available for you to browse and review. And we'd like to also invite everyone to take a look also at our upcoming webinars as well. And we hope to actually see you there too, and encourage you to visit. So with that, thank you again, Lava. Thank you, Nathan. Thank you, Drew, for your time. And thank you, everyone, for joining us today's webinar. And we look forward to seeing you again soon. Thank you, and have a great day.